Perfect. Great. So welcome everybody. Thank you so much for joining us tonight. Thank you especially to the Complementary Integrative Medicine Committee, Dr. Lewis, and the rest of the committee members for organizing this event. I think it speaks volumes that we've had so many people sign up for our event tonight and to join us this evening. The importance of this topic and the hard work that the committee's put into this. I also want to thank APA Inc. for sponsoring the event tonight. In particular, Christine Cotter, who is with us this evening from APA Inc. and for their support of NYCPS and all the work that we do throughout the year to support New York City psychiatry. And so with that, I'll just turn it over to Dr. Lewis to tell us more about tonight's event.
Hi, so welcome everyone, good evening. Thank you for, and maybe what we discovered is that actually 8 p.m. is a great time for a talk. The Complementary and Alternative Medicine Committee, also known as Integrative Psychiatry Committee, has been meeting about once a month for talks on various topics. And so I send out the emails and those have been well attended, but this is a special one for New York County Psychiatric. And we are happy to have more people join the committee. So I think it's basically reaching out to me or reaching out to Megan to just express interest, and I add you to the email list that I keep, and then we have talks once a month. And tonight's talk is special. So Dr. Chad Boseman gave a talk at the APA. I attended the APA in person. Maybe was it in November? And this was one of my favorite talks. So we connected after the talk, and I appreciated your talk there. And it's, you know, genetics and how to use genetic testing results in actually clinical practice are such a real and active topic for many of us. And many of us are testing, but not really necessarily fully understanding how to interpret the results or how much to trust various results. And there's so much, and in the field of integrative psychiatry, some people have, you know, various pet interest genes that, you know, MTHFR or BDNF. So to have an expert who really considers like the science of it and knows all the research and is deeply involved in like understanding how the testing works, I think is really useful for us. So welcome. Thank you for joining us tonight. And I'm looking forward to your talk, and I'll let you introduce yourself and all your like academic background yourself.
Great. Well, thank you, Dr. Lewis, for that. I realized that I can't share my screen. It says the host is disabled. But maybe while that's getting set up, I can just introduce myself. So still can't do it. There we go. Oh, yeah, thank you. There you go. So hopefully everyone can see that. So yes, so my name is Chad Boseman. I'm an associate professor in the Department of Medical Genetics at the University of Calgary, and I lead a program of research related to implementation and discovery of pharmacogenetics, particularly in psychiatry, and more specifically antidepressant and antipsychotic treatment. Now, as I get started, I also want to say that I also have a dual role as the founder and CEO of Sequence to Script, which is a software tool that helps individuals translate pharmacogenetic information into evidence-based recommendations, which I'll get into a little bit closer to the end of the talk. So I have three main learning objectives for you guys tonight. The first is to explain the rationale and evidence for using pharmacogenetic guided prescribing. Then I'm also going to kind of sprinkle in some care situations where pharmacogenetic testing could be useful, and then finish off with a description of some of the key considerations for using pharmacogenetic guided prescribing in practice. So to get started, I like to start with this quote because I think it really captures the current state of prescribing, but also highlights quite nicely the need for more personalized prescribing strategies. To put this another way, if we look at the population level, we know that medications are typically efficacious and tolerable. If they weren't, they wouldn't be approved by regulatory bodies such as the FDA. But if I select someone out of that population at random and look at the individual level, it often looks something like this, where efficacy and tolerability can vary substantially. And so we're left with a situation where we need to determine which drug fits in which one of these quadrants for a particular individual. And again, I think this really highlights the need for more personalized prescribing strategies. So here I'm listing a few of the more commonly known personalized prescribing strategies, many of which have been around for decades and are considered standard of care. Now, of course, today we're going to be focusing on the new kid on the block, pharmacogenetics. But before I dive in, I just want to make a point of saying that pharmacogenetics is not meant to replace any of these currently used and standard of care prescribing strategies. It's more of a companion or to enhance these other strategies. So what is pharmacogenetics? I'm sure many of you already know, but just to make sure we're all on the same page, pharmacogenetics uses genetic information to predict a person's ability to process and react to medications. Now, we typically lump this genetic information into two broad categories, pharmacodynamics and pharmacokinetics. And to date, the majority of the evidence base and the research has been focused on that second group, pharmacokinetics, and more specifically in the area of metabolism. So when we think of metabolism, we often think of the drug metabolizing enzymes. And over the last few decades, there's been a number of pharmacokinetic studies that have nicely shown the association between genetic variation in genes that code for these drug metabolizing enzymes and enzyme activity. And so we can lump this enzyme activity into 5 broad categories, ranging from poor or slow metabolism to ultra rapid or fast metabolism. And if we know someone's phenotype, we can typically reasonably predict how much of the drug will be in their blood at the standard dose. So those individuals that are at that poor end of the spectrum or slow metabolism, we'd expect higher drug concentrations and a higher risk for side effects. Whereas those on the ultra rapid side of the spectrum or fast metabolizers are going to have lower drug concentrations and be at high risk of receiving no benefit from the drug. So of course, this is great. It gives us this correlation, but which genes and which drugs is always the question. Can we apply this to? And so, of course, to do this, like any other area of medicine, we need to go back to the evidence base, which would include the published literature, but also in this case, drug labels. Now, fortunately, in pharmacogenomics, we have PharmGKB, which is the pharmacogenomics knowledge base. This is a group based at Stanford that's NIH funded, that basically pulls out all of the gene drug pairs from the literature and drug labels. They curate that information and then they score it on the strength of evidence scale, ranging from unsupported to high. So the unsupported gene drug pairs, as the name would suggest, does not have current associations between the gene and the drug. The low strength of evidence is where we see a single positive study between a gene and a drug, or there's a number of studies that have been done, but there's mixed or conflicting findings. The moderate strength of evidence is where we start seeing multiple replications, but the effect size is small, and some would argue that it's probably not clinically meaningful. And then the high level of evidence, which is we get multiple replications, but now we see large enough effect that could have clinical meaning. And it's these gene drug pairs that meet that high strength of evidence that get pushed through to the guideline development pipeline. And here I'm showing you the 4 main guideline developing groups. The 2 top ones here are the most prominent and have produced the most guidelines to date. So the first one being the Clinical Pharmacogenetics Implementation Consortium, which is based in the US, but has an international membership, and the Dutch Pharmacogenomics Working Group, which is in the Netherlands, of course. Now, all up, these four guideline developing groups have developed prescribing guidelines for 115 gene-drug pairs, comprising 25 genes and 88 drugs, which is shown here in this relatively busy chart. But I like to show this because I think it really highlights that these prescribing guidelines aren't specific to any one particular drug class or any one area of medicine. Now, of course, today we're going to focus on psychiatry. So I've focused in on the 37 gene drug pairs comprising 6 genes and 29 drugs that are most relevant to psychiatry. And I think you can appreciate right away that 2 genes pop out here as being quite important, CYP2D6 and CYP2C19. And so you can see that they're connected to the majority of these prescribing guidelines. And in fact, they are considered the workhorse genes at the moment in pharmacogenetics in psychiatry. I also want to mention that in addition to the guidelines in those groups that create those guidelines, the International Society of Psychiatric Genetics in 2020 convened a group of experts to review and come to a consensus on pharmacogenetic testing in psychiatry. And in 2021, they published their findings. And what they reported was that the current evidence supports pharmacogenetic testing for specific antidepressants, antipsychotics, mood stabilizers, and ADHD medications. But they also reported that at the current moment, the evidence does not support testing for anxiolytics, addiction medications, as well as genetic variants in a number of pharmacodynamic genes. And that's not an exhaustive list there, just some prime examples of ones that don't have a good evidence base at the moment. So now I thought I'd just share with you a case example of how pharmacogenetic testing may be clinically useful. So this case is a 67-year-old male with a diagnosis of major depressive disorder. He was admitted to hospital with suicide ideation and catatonic symptoms. And prior to his admission, he was given trials of citalopram and escitalopram at maximum doses, but he showed minimal response. And so the decision was made by the treatment team to start ECT, in which his mental state did improve. And then he was prescribed sertraline prior to discharge from hospital. Unfortunately, shortly after his discharge, his depressive symptoms reoccurred and he was readmitted. And this is when the treatment team decided to order pharmacogenetic testing. So here's just a summary of those results. So you can see here, this gentleman was a CYP2C19 rapid metabolizer and a CYP2D6 normal metabolizer. So let's unpack this a bit and look at the evidence. So first, just as a reminder, this gentleman was trialed on 3 drugs, all of which are CYP2C19 substrates. If we look at these 3 drugs, their drug labels, we see that 2 of them, citalopram and escitalopram, do mention CYP2C19 genetic variation as something to consider in dosing considerations. And then if we look at the dosing guidelines from CPIC, all 3 drugs do have guidelines, and they suggest that an individual that is a CYP2C19 rapid metabolizer, that we should consider an alternative drug not predominantly metabolized by CYP2C19. And then finally, if we look at Pharmacogenetic, we see that all 3 of these gene drug pairs are rated as a strength of evidence of high with multiple replications and a large effect. So based on these, based on this evidence, the sertraline was discontinued and paroxetine was commenced. And just to remind you that paroxetine is a CYP2D6 substrate, and this gentleman was a CYP2D6 normal metabolizer. And then the patient was discharged 3 weeks later, and he remains well in the community with no further relapses. So the take-home message here is that pharmacogenetic testing could significantly reduce these types of experiences, particularly maybe expediting the time to finding a medication that works. In this case, it was the fourth drug that they trialed that finally worked after having pharmacogenetic testing, and may avoid unnecessary treatments. In this case, it is arguably that ECT wasn't necessary if paroxetine would have been prescribed sooner. So up until this point, I think I've hopefully summarized for you that there's a good amount of pharmacokinetic evidence and rationale for pharmacogenetic testing. There's guidelines from groups to help guide that testing and interpretation. Professional societies have also come to consensus on its potential clinical utility, and there's certainly case studies that demonstrate that. But despite all of that, adoption of pharmacogenetic testing still is quite modest in practice, particularly in psychiatry. And I'd say as a whole, we're in this early adopters phase on this innovation distribution curve. And we're approaching, if not right on the cusp, of what they call the chasm, which is where these innovations or technologies will either sink or swim. And the idea being, if you make it through the chasm to the early majority, you'll get traction and become standard of practice. So at the moment, as a field, we're at this point of, can we cross this chasm? And in order to do that, there are a number of considerations around implementing pharmacogenetics that need to be thought about and addressed. And so these are just a summary of those, and I'm going to try to touch on each one of these in the second part of my talk briefly, but I'm actually happy to answer any questions that I don't get to, because this is a lot of ground to cover in the time that we have. So the first consideration is the selection and ordering of testing. This is by far the number one question I get asked, is what test should I use? And because my colleagues and I get asked this so often, we developed a guide to test selection and this decision tree, which I know is too small for you to read, but I'm going to boil it down into the four basic best practices for when considering a particular test or laboratory. So first, we want the test to be evidence-based, of course. So going back to that busy figure that I showed you before, we want to make sure that the genes and the drugs that are being tested have guidelines. Second, we want to make sure the laboratory is accredited. So this will ensure a good amount of analytical validity to the test. Second, we want some transparency from the laboratory. So what I mean by that is they should be able to tell you what they're testing, how they're testing, and most importantly, their process for translating the genetic information into that prescribing recommendation. If they're unwilling or unable to provide you that information, I would definitely suggest moving on. And then finally, it needs to be supportive. And what I mean by that is we can't have the testing laboratory should provide more than just the genotype and the phenotype. It does need to have some type of support, some kind of clinical decision support, whether that be a consultation or access to experts that can help interpret the results, whether that be in person or phone or through some kind of app. This is something that's definitely necessary for proper implementation. And the last thing I'll say about this topic is that of all the tests that I've looked at and reviewed, there's no test that is superior to all others. But there are inferior tests, and this is why we created this guide to test selection. If we follow these best practices, you're almost guaranteed that you can avoid these inferior tests. Okay, the second question around selection and ordering that I often get asked is who should be offered testing? And so the best kind of put this into perspective, I've broken it down into three cohorts, age cohorts. So first, the young people. The evidence really is still emerging here, but it is promising. And it's arguably the ideal population to implement testing. And this is just for the practical reason that we know that these young people have their life ahead of them, and the amount of medications that they may need to take or be exposed to is greater than if we did testing later in life. So there's a greater cost savings potential. And the evidence to date would suggest that pharmacogenetic testing could be useful in this population for SSRIs, with the exception of fluoxetine, which does not have a current guideline, and risperidone and aripiprazole. And then I want to highlight that stimulants at the moment really don't, pharmacogenetic testing is not going to help with prescribing of stimulants at the current moment. And so I'd advise not ordering pharmacogenetic testing if that is the main reason for the testing, because it's really not going to help much with the stimulant prescribing decisions. Then moving on to adults, this is where we really have the strongest evidence base, particularly in major depressive disorder, and this is where most of the implementation is occurring. The evidence would suggest we should consider pharmacogenetic testing when starting a drug with a pharmacogenetic guideline, where there's no response despite high adherence or side effects at low doses. And there's emerging evidence to suggest that pharmacogenetic testing may be useful in patients that are reluctant or have low adherence to pharmacotherapy. And then in older adults, similar to young people, there's minimal but promising evidence. But this is arguably the most challenging population to implement testing. And this has a lot to do with the known polypharmacy in this population, as well as pharmacokinetic changes that occur with age. And the clinical indications are more or less the same as adults, just with a little bit less evidence to support them. And there's also emerging evidence to suggest, excuse me, to suggest that pharmacogenetic testing may assist with deprescribing decision-making. Okay, now I'd like to move on to content validity. And so what I mean by this is we know that the current regulatory status of pharmacogenetic testing is not very tight. So basically, laboratories can pretty much test any gene that they want to within their testing frameworks. And this leads to cautionary content. And what I mean by cautionary content is genes that have good face validity and good biological plausibility for a particular drug. But when we look at the clinical validity, it still is inconclusive. And so I'm going to put up here 5 examples that of cautionary gene-drug pairs. This is not by any means exhaustive, but these are some of the primary ones that show up on many of the panels to date. In fact, you can see here in these pie charts, it's a non-trivial amount of panels that include one or more of these gene-drug pairs that are considered cautionary. And now I want to share with you another case example of why this cautionary content can be problematic. So this was a 25-year-old male diagnosed with schizophrenia. He was admitted to hospital on an involuntary basis due to bizarre behavior and command hallucinations. And he had a history of multiple medication failures, which led the treatment team to decide clozapine was the next best step. Unfortunately, the patient's family and family doctor opposed this decision based on pharmacogenetic testing results that were ordered by the family doctor previously. And here's a summary of those results that were ordered by the family doctor. And you can see here, it's pretty much unremarkable, a normal metabolizer across the board. But this particular laboratory where they ordered the test from included this gene, DRD2, which is the D2 dopamine receptor, and this particular variant in that gene, and suggested that this gentleman's genotype for this variant would predict him to be a poor responder, and specifically highlighted clozapine. So based on these results, the patient's family and family doctor were opposing the start of clozapine. So let's look at the evidence base for this gene-drug pair. So first, if we look at the drug labels for clozapine across the different regulators, we see that there's no mention on any of the drug labels for DRD2 genetic variation affecting response to clozapine. Also, if we look at the dosing guidelines from the 4 major groups, there's no guidelines for either DRD2 or clozapine. And finally, if we look at the PharmGKB, we see that this particular gene drug pair gets rated as a strength of evidence low, so not yet replicated or conflicting findings. And in this case, it's the latter. So in the end, the clozapine was commenced after getting approval from the medical director and getting patient consent. And the patient responded rapidly and he was discharged and he gradually returned to his previous level of functioning. So the take home here is that we need to be diligent about only implementing gene drug pairs that have prescribing guidelines. When we stray away from these evidence-based guidelines, we risk taking potential efficacious drugs off the table. Or we can look at it the flip way, we also potentially risk prescribing medications that are not appropriate for the particular patient. Okay, so this is something I also want to touch on is the clinical efficacy. So I mentioned earlier in my talk, there's the definite link between genetic variation in these metabolizing enzymes and drug concentrations, blood drug concentrations. But the question always gets asked, well, that's the drug concentrations, but does it actually associate with clinical efficacy? And so this is a meta-analysis that we just completed and published last month that looked at all 13 clinical trials that have been conducted on pharmacogenetic testing for informing prescribing of antidepressants. And so there was 3 open label trials and 10 randomized control trials. And if we look at the pooled risk ratio, we see that patients that receive pharmacogenetic guided antidepressant treatment were 41% more likely to remit relative to patients receiving standard of care. So there's certainly some evidence here suggesting that it's not just blood concentrations, but there's also clinical efficacy here as well, particularly around antidepressants. And then similarly, often goes along with clinical efficacy is the cost effectiveness. And I can say that most evaluations suggest pharmacogenetic testing is cost effective or cost savings when compared to standard of care. And this is a nice review that was just published this year. And if we look specifically at the 11 studies for antidepressant therapy, we see that majority of the studies showed it was either cost effective or cost savings. I also want to highlight one specific study that was done by Roy Peerless at Harvard and showed that offering pharmacogenetic testing reduced healthcare utilization, particularly hospitalizations and emergency room visits. And then there were 3 other studies that have estimated the per patient savings per year somewhere between $6,000 and $7,000. Okay, so next consideration I want to just touch on briefly is feasibility. This is one of the biggest, if not the biggest, challenges for pharmacogenetic implementation. And there's a lot of things that can fit under here, but I'm just kind of cherry picking what I see as the top 3. So one of those is the integration of pharmacogenetic test results into the electronic health or medical record, which few institutions have accomplished successfully at this point. So currently, most of us work in systems where we're at this, what we call level 4, level 3, where the pharmacogenetic test report is standalone. It might be in a paper file somewhere or just with one physician. Or level 3, where it's uploaded into the EHR, but if you don't know where it is, you'll never find it, and there's nothing to kind of link you or alert you to that it exists when prescribing. And of course, we want to shift to the right and get to that level 1, where it's fully integrated into the EHR with alerted best practice alerts or some kind of functionality to alert prescribers of these results in real time. The second feasibility issue, which is the most consistently reported in the literature, is the healthcare provider confidence in their pharmacogenetic knowledge. And so this is definitely improving. Obviously, pharmacogenetic testing is relatively new. So medical schools haven't really included pharmacogenetic testing in their education. Pharmacy schools are starting to do it. So this is something that is considered to be very important to implementation. Obviously, if someone's not confident in their knowledge of an innovation, they're less likely to use it, or less likely to feel confident about how they use it. And so this is something that is a main area of focus in the field. And then finally, always the elephant in the room is the affordability of the testing. It ranges widely within a particular region and even across regions. And there is certainly variable and equitable reimbursement, both within a country and across countries, about how this testing is reimbursed. And then the last thing I'll say is that we've done some analyses to show that the test cost does not correlate with quality. And so certainly don't make decisions based on the cost of the testing. You definitely don't necessarily get what you pay for when it comes to pharmacogenetics. Okay, and the final consideration is interpretation. And I'd like to finish with this because I think this is probably the most relevant to this audience, who are going to be, at the end of the day, the ones looking at the information and interpreting it and determining whether or not they're going to implement it or not. And we know that pharmacogenetic testing results can be a challenge to interpret when there's no accompanying clinical decision support. So this goes back to that first consideration where I said when we're selecting it, we need some kind of support. We can't just give genetic or give genotypes and a phenotype and say, yeah, use this. There has to be some type of support around that. And we know that. What we didn't know was whether or not all the clinical decision support that was being provided by these laboratories, if it was equivalent. And so we did a head-to-head comparison of the pharmacogenetic test results from 4 independent laboratories, which at the time were the only 4 that had RCTs to support their testing. And so we selected those 4. And when we compared those results across patient or within the same patient, what we found was there was less than 60% agreement in the advice given across the tests. And so what this really told us was that we cannot assume that these clinical decision supports are equivalent or interchangeable. But it also highlighted that, or I guess raised the next question, was why? Why are these so discordant in their advice? And what it comes down to, or one of the major issues, it's not the only thing that explains it, but one of the main ones is this black box, or these proprietary algorithms, another way to put it. So all of the laboratories provide the pharmacogenetic test, the genotypes, and we look just the genotypes, they have really pretty high concordance across labs. The discordance only happens after we start looking at the recommendations that are associated with the results. And so that means that there's something happening in the middle there, which we're terming the black box, that's changing the recommendations. And so we typically know what's in the black box, like the ingredients, but we don't know what proportion of the ingredients they're using to make the recommendations. So they often mention that they're using, the published literature, the drug labels. They may cite PharmGKB, and they may even cite some of the guidelines, but we don't know how they're weighting that information to make the recommendations. So this becomes difficult to determine how evidence-based these recommendations are. So one way around this is, one way is to bypass the black box. So all of these tests provide the actual genotype. So the genotype can be taken directly to the guidelines, and because these guidelines are complete open access, you can cross-reference them directly with the drug of interest and get the actual guideline, and you can just bypass this whole proprietary algorithm. Of course, most of us don't have the time to just do that for every single patient and for every genotype we receive. And so software has been developed. And as I mentioned in my conflict of interest, one of those tools is Sequence to Script. This is a free tool. So there's no cost to use this. You can, if you have a genetic result in front of you from a laboratory and you're not sure if the recommendation follows the current evidence base, you basically can enter that genetic information into Sequence to Script. It will pull only the evidence base into a compiled report. And basically you can reverse engineer it. You could do this all on your own. It's just streamlining it for you so you don't have to go hunt for all the guidelines. And it'll give you more than just the drug you want. It'll give you all the drugs that are associated with that genotype. So it's just one tool that is available. You can consider it or think of it as a second opinion tool. And the last thing I'm going to mention around the interpretation component is that we need to consider non-genetic factors. So we obviously been talking about just the genetic factors, but non-genetic factors can certainly impact the interpretation of pharmacogenetic test results. And this is a phenomenon known as phenoconversion. And this happens when there's a mismatch between the individual's genotype predicted metabolism or phenotype and the clinically observed phenotype. So let me give you an example. So if we say that I genotyped an individual for CYP2D6 and the result comes back that they're a normal metabolizer based on their genotype, but then I look at their drug list and I see that they're currently taking fluoxetine. And we know that fluoxetine is a potent CYP2D6 inhibitor. So as long as they're taking fluoxetine, that genotype predicted normal metabolizer will be discordant with their clinically observed because they will phenoconvert to a poor metabolizer because of that inhibition. Of course, if you take fluoxetine out of the equation, they would revert back to the innate normal metabolism. And just to give you an idea of how often this may occur, there's a study done about 900 patients treated for depression, and they genotyped those individuals for CYP2D6. And they found if you just look at genotype information, 4% would be classified as poor metabolizers, which is what we'd expect, about 4 to 6% in the European population, which is where this study was conducted. But then they looked at their drug list of these 900 patients, and based on whether or not they were taking inhibitors of CYP2D6, and based on that, 27% would be considered poor metabolizers. So you can see there's quite a bit of a difference here. This wasn't an older aged cohort, so more polypharmacy or more multiple drug prescribing may not be as drastic if you're treating children. They may not be taking as many medications, but nevertheless, ignoring the fact that the non-genetic factors can lead to interpretation errors. Okay, so I have 3 take-home points. First, hopefully I've demonstrated that pharmacogenetic testing is an evidence-based strategy to inform prescribing of commonly used psychiatric medications, particularly antidepressants. Number 2, when using pharmacogenetic testing, I think it's imperative to stress that we really need to adhere to the available guidelines and not forget about those non-genetic factors, which I just mentioned can result in phenoconversion. And finally, just to reiterate what I said up front, that pharmacogenetic testing is meant to be a companion decision support tool that can enhance, not replace, current prescribing strategies. With that, I'll end, and I thank you for your attention and for the invitation to speak to you, and I'm happy to take questions.
Thank you so much, Dr. Boseman. And we are open for questions. So please, you can use the raise hand signal or type questions into the chat. It's nice to hear people's voice. So if you want to raise your hand, that's great. And then unmute yourself. Okay.
I do see a question in the chat.
Yes.
I'm assuming everyone can see that, but so the question basically was, in that first case that I presented, would you consider increasing the dose above the recommended maximum for any of the 3 original SSRIs? So that was escitalopram, citalopram, and sertraline. So first, I should have maybe even put up front as a disclosure, I am not a psychiatrist. I'm not a prescriber, but I would, as someone that sits on the guideline development and hearing prescribers talk about this, the reason why the guidelines don't recommend that is obviously we don't want to go against FDA maximums. And we don't really know how far you have to go with some of these individuals. So a ultra rapid metabolizer, we don't know, how much you'd have to increase, or if there is an even amount you could increase for it to actually to work. So I would say be very cautious with that approach. And certainly the guidelines would not advocate for that.
Can I just follow up on my question? Hi.
Sure, yeah.
So I guess I was asking because obviously we would probably, if someone is a poor metabolizer, we might consider going to a lower dose or half the recommended minimum. And just for the same reason that, probably most of the pharmacokinetic studies, even especially if they were older and they weren't looking at these, genetic testing wasn't available when the studies were the drugs were studied, that it averaged out to people being normal metabolizers in terms of the population that were studied. And so that's how they came up with the dosing guidelines. But of course, would there be consideration for higher doses, because it's based, I guess the question is it kind of the same thing as taking, we don't know what it is, but if you give someone 30 milligrams of Lexapro, who's a ultra rapid metabolizer, could that theoretically be like 20 milligrams or 15 or something like that?
Yeah, it's a good question. The evidence for it though is not there. I can say that. The halving the dose in poor metabolizers, the evidence is there, and I guess that's a bit more.
I see.
There, yeah, and it's obviously a much more conservative approach as well versus upping a dose. I think based on the conversations that we have in those rooms, is people are very reluctant to in any of our guidelines to say higher dose, unless we can say it comfortably within the FDA range. But I know for a fact they'll never say go over the FDA range, mainly because FDA is a silent kind of contributor to the CPIC. They kind of flies on the wall. So I'm pretty sure if we started to say we're going to go recommending over the FDA, they would no longer be a fly. They would.
Is there a chance that they'd reconsider some of the dosings once in consideration of various pharmacogenetic profiles? That the FDA would study that and is that a direction that I'm just curious, is that a direction that the field is looking at?
Yeah, we're definitely trying to get the FDA more involved, right? We want to be working with them, not against them. And I think they are coming to the table. The pandemic derailed a lot of that, of course, but I think it's coming back. And now they're requiring new drugs to go through more pharmacogenetic screening because they understand that. So it's more about now, how can we go back? A lot of these drugs are generic. Who's going to pay for it? Who cares? Kind of thing. So that's the challenge. It's landed on academics to do this independently and get funding to do it. So of course that has its challenges.
Right. Thank you. Thank you for a really, really informative and wonderful talk.
Thank you. Just looking here. So Stephanie says, please review again CYP2D6 story with metabolism of risperidone and aripiprazole. So I don't know if you can maybe elaborate a bit on that, but what would you like me to say more about on that one? Stephanie, are you willing to speak? Oh, you're muted, Stephanie.
Can't hear me. Yeah, I missed I wasn't actually online when you really were going over that. Just very simple. It's not an intricate question, just kind of the very, very basic idea about the testing for that and kind
Yeah.
of, I think you mentioned antidepressants are really the big guns, but if you could just talk a little bit about those two antipsychotics since they're the two you mentioned.
Yeah. So currently, there's only one group that has guidelines associated with those two drugs. That's the Dutch pharmacogenomics group. So CPIC hasn't published guidelines yet. They will have them soon. The group has been formed to review the evidence, but the current evidence, the current guidelines would, it's more related to poor metabolizers of those two drugs and the ultra rapid. So the two extreme phenotypes, and the ultra rapid meaning probably avoid or select a drug not metabolized by CYP2D6, and then the poor, I think both of them are 50% of the standard dose for the poor metabolizers. But intermediate metabolizers, there is no guideline for those individuals. So you're looking at about, depending on the population, somewhere around up to 10% of the population would fall into one of those actionable categories.
Okay, all right, thank you. Thanks a lot.
Okay, and then and then someone, what do I think about GeneSight and Genomind? Yeah, I probably should not talk specifically about any one test. Yeah, and I know both of those are heavily marketed in the US, more so than here in Canada. We have our own conglomerates, but yeah, those two I know are in the US. The only thing I would suggest is to kind of really apply that those 4 best practices when looking at those tests. And I'm happy to talk offline to people if they have questions, but probably I'm not going to say it in a public forum. Okay, and what is the current state of evidence on MTHFR testing and folate, as well as BDNF and exercise? So MTHFR and folate, there really isn't much to say about it. There's not any evidence to support it, and it's just not much evidence, right? So there's just not enough studies. So in the study, I think there's maybe 1 or 2, and they're so small that we can't even make any really interpretations from it. Now, that's not to say that you shouldn't use folate. I personally think if folate, you want to use it, go for it. But it shouldn't be based on someone's MTHFR profile, their testing, because the testing isn't going to make a difference. The evidence to date doesn't suggest it's going to make a difference. So it's a relatively low risk intervention in the first place. So if you're going to use it, I would just use it as you normally would, and not let it be guided by MTHFR. Unfortunately, a lot of the labs have grasped onto that because, again, it has really good face validity and really good biological plausibility. Of course, the MTHFR protein has an impact on folate, but that doesn't necessarily mean the genetic variation in that gene that codes a protein has any effect. And so you kind of have to dissect that a bit. And right now, the evidence, I mean, I wouldn't support ordering that. I've tried to talk to many of these commercial labs to taking it off their panels, but I have a feeling it's one of their money makers because they're very reluctant. I don't know why they're keeping on it otherwise, but the evidence is not the reason. So, and then BDNF and exercise, I can't speak to that. I'm not really familiar with the literature on the exercise bit, but I can tell you that there's BDNF for any medication guidance. It would fall in the same boat as MTHFR. But for exercise, I don't know. That's a bit outside of my expertise. Okay. Okay, and then the next question, for the study that looked at phenoconversion, did they find that the phenotype or poor metabolizer was based only on the fact that they were prescribed inhibitors of the CYP2D4 system, or were the patients given a drug? But yeah, so it was the drug that they were looking at in that study was venlafaxine. So I do believe they did have, they did some therapeutic drug monitoring to verify it. I'd have to go back and look, but I'm pretty sure that they did to verify that. I just gave a very brief summary of that. I kind of skimmed over that, but I'm pretty sure that they did look at the metabolite parent drug ratio, as you mentioned there. So I think that's all the questions in the chat. I don't know if anyone wants to.
More questions? Anyone? Oh, we have a raised hand. Okay. Dr. Begum, yeah, please unmute and you can ask. Yeah.
Hi. In psychiatry, we deal a lot with patients who are refractory to medications. What is the role of pharmacogenetic testing in those patients?
Yeah, I think it really depends. So one of the areas that we do a lot of work here in my lab is in treatment-resistant schizophrenia. And of course, that's focused on clozapine, and we don't have any good pharmacogenetic tests for clozapine, as my case example showed. But like treatment-resistant depression, it may be helpful. And even in treatment-resistant schizophrenia, I should go back and say it can be helpful in helping explain maybe why they're resistant. So there's that concept of pseudo-resistance. Like maybe the reason, because we define resistance as 2 failed appropriate drug trials, duration, dose, all that, right? So if you were to happen to use 2 drugs that were basically targeting the same metabolism pathway, and that pathway is perturbed, you could label someone as treatment resistant, but it's just because they weren't given a drug that they could tolerate, or they metabolized it too fast, so they didn't respond. So it could help in that sense if you want to rule out potential pseudo resistance. For treatment resistant depression, because so many, we have a lot more guidelines around antidepressants, I think it could be helpful in trying to reduce the amount of trial and error that happens after the first lines maybe aren't working. So particularly because you're going to start thinking about tricyclics, potentially you're going to go beyond the SSRI class is what I'm saying. So then pharmacogenetics still can help there. Probably more so in depression than anywhere else.
Thank you.
And I thought I seen Seth had his hand raised, but maybe no longer has a question.
That was an accident. I meant to do this.
Thank you.
So you have a very conservative guidance for us, right? I think within psychiatry. So I wonder also, so it's unclear. So what percentage of psychiatrists are using this to actually guide their prescribing? Is there a statistic? Like how?
It depends on the country, I think. But in the US, so in the US, I haven't seen a recent estimate. The last estimate I've seen, which is probably now 15 years old, so I'm guessing it's going to be much higher, was 15%. But I didn't believe that at the time, to be honest, because I don't even know how you can get that estimate, because there's so many different providers. There's no really tracking of it, and I would say most of the implementation is happening in the United States. Because of the reimbursement that's happening. So reimbursement drives implementation. And so in the case of now that Medicare, I think Medicaid even now will reimburse pharmacogenetic testing for specific indications, that has launched the use of it, as well as people willing to pay out of pocket as well, of course. Whereas in other countries, it's a bit tighter regulation about it, where it's only out of pocket. You have to use it as, there's no coverage. Like in Canada, there's no reimbursement at the moment. Well, that's not true. There are some, but very few people get reimbursement. You have to be employed to get it. And it's yeah, there's all kinds of stipulations. Nothing like in the US where it's much more reimbursement opportunities.
Mhm. And all kinds of things are reimbursed beyond the very few things that you actually are recommending as like evidence-based, right? Because these panels, like Genomind, there's, I don't know, 12 things or more that at this point you're saying are not supported by evidence, but clinically we're using them.
Mm-hmm. Yeah, it's a bit of a tightrope. Like, so from if we're just saying evidence-based, it's and for psychiatry, it's just basic CYP2D6 and C19. Now, they show those clinical trials I showed you and that forest plot that I showed you, that meta-analysis we did, all of those studies used laboratories that tested more than just CYP2D6 and C19, right? So they included, like, Genomind was one of those studies, was Genomind. There's a couple of GeneSight studies and a couple other, right? There's, I think maybe of those 13 trials, there was 7 different test laboratories that were included. And all of them have their own home brew of panel that they have. The only thing that ties them all together is they all have CYP2D6 and C19. That's the only commonality. The rest is all unique, and that's not by accident, right? They're trying to show that they're unique to their competitors, right? So it's more of a marketing thing than anything. But what we don't know is if you took all those things away, will we still see the effects that we do? So how much of the effect is from these other genes? We can't answer that because they don't give us access to their algorithms or how much they weight these things. And so it becomes a challenge from an academic perspective, trying to outsider view, trying to dissect that. So yeah, it's a difficult one. I mean, yeah, the evidence says that it works, but is it those, or is it the CYP2D6 and C19? The biggest example is the serotonin transporter. So a lot of them will include serotonin transporter, and that'll get combined with the P450 genes. But then you're like, well, how do you dissect that? Where's the result? The recommendation is it more based on the P450? Is it based on the serotonin transporter? So you don't really know. You can sometimes reverse engineer it pretty easily, but other times you're left kind of scratching your head. So personally, I would say I would only use CYP2D6 and C19 for now, for just, yeah, that's where the evidence is. You're less liability, that's for sure, if you're using just CYP2D6 and C19. I think, yeah.
I wonder, is it a question of time? Like in another 10, 20, 30 years, research will accumulate on these additional genes included on these large panels, and it's just right now it's kind of like an early phase and it's just clinical judgment because there's so little research. So are we just waiting for that, and we might be in the early adopter kind of clinical?
Yeah, I think some of them for sure. Some of them are on the cusp, and guideline developers are more conservative, but others, I just don't see it happening anytime soon, because it's such a messy, the literature, it's not about lack of evidence, it's the evidence that exists is so mixed and messy that I don't know how you can make heads or tails of it. So like the case of MTHFR, right now I don't support it because there's just no evidence, but in 10 years time, if enough studies, we may be talking, I may be saying something completely different. I may say, yeah, you should be using it. But right now there's no indication that it helps you at all. On the other hand, you have this DRD2, like I used in my case example for clozapine. There's a lot of studies, and some of them say yes, some of them say no, and it's, and I wouldn't say one side is better done than the other. So it's a really mixed bag. So I don't know if is more studies really going to get us to where we need to go. I mean, there's just so much uncertainty there. And serotonin transporter goes beyond just that's another one that's like on the cusp, I would say. But it has non-genetic issues with implementation. And that's the problem with it, because particularly in a population like the US that's more admixed population, where you don't just have, all Europeans or serotonin transporter. If some of you that have implemented it know, if you're a short carrier, the report will say you're going to be a poor responder to an SSRI. But the evidence is only true in European populations. If you look at an Asian population, it actually trends the other way. They're possibly maybe a potentially better responder. It's not, I wouldn't say that's not statistically significant or anything, but it's going in that direction. It's going the opposite. So that's why it doesn't have a guideline. It's just there's other things to take into consideration for that particular gene, and the way that it's tested as well, because it's not just a SNP. It's a repeat. It's a variable number tandem repeat polymorphism, which is a bit trickier than just a couple SNPs. So there's also feasibility issues with that one.
Okay, so out of all the other genes, is the serotonin transporter and DRD2 that have like the most evidence, the most research, but it's just too mixed at this point.
Well, I'd say DRD2 is mixed. As the serotonin transporter, the evidence is I think pretty good for European population, but the problem is the current evidence is based on SSRIs mostly. But we don't know if you're an SAT, a short carrier. I wouldn't feel comfortable saying don't prescribe SSRI, but that you can prescribe an SNRI, because we don't know. So the problem is the recommendation. What's the alternative? If we can't offer an alternative, then we shouldn't be testing it, because we don't know like what to do. So that's kind of where we're at with that, and recommendations is we don't have a suitable alternative, or TCAs. We don't even know, does the short individuals, are they going to respond less to TCAs? We don't know. The evidence.
And yet that's what's on the recommendations of the test. And they sound very confident. So basically you're saying all of that is based on very little, if anything, like there's no evidence, and yet they're giving us these very confident.
Yeah, exactly. So that's why I have the serotonin transporter as a cautionary gene drug pair, because I think there's still too much uncertainty there. I will say that the evidence does suggest that SSRI response could be attenuated in someone of European background that has short. But then you get into the trap of, how do you know if someone's European background? You can't just look at them and do it that way. There's definitely examples of that going awry. Someone may look European background, but their genetics show that they're Asian. So you can't. That's the trickiness. You can't really just look at someone or go on self-report and determine whether or not the short is going to behave in the way you think it's going to. So I think in time, though, we'll figure this out. But right now, I just avoid it, because I think you get yourself into trouble.
Well, they're just included on the panel, so it's hard to avoid.
Well, I ignore it, basically, is I guess that's the other thing I didn't mention when I was talking about the cautionary gene drug pairs. I don't think that just because they're on a panel means that the panel is useless, because a lot of the panels, like I said, all of them have CYP2D6 and C19. So you can still use that information. Just, be very careful with the other information. Obviously, it's your prerogative if you want to use that, but I would advise strongly against it and just focus on the evidence base.
And for DRD2, what's the evidence at this point?
Well, so that would be mostly it's in antipsychotics, and and a lot of it's been related to the adverse drug reactions with antipsychotics, not response as much, but it's not strong, not ready for implementation for sure. Again, very mixed findings there. And when the effect sizes are significant, or the findings are significant, the effect sizes are, I think, a bit small for them to be clinically meaningful. So, yeah. Not many people are focusing on DRD2 anymore. I think a lot of the the pharmacogenetic science groups have kind of moved away from DRD2 for the most part, which tells me that we're giving up on it. They don't think that there's a chance that it's going to be helpful from an implementation standpoint.
Okay. Other questions?
He says that bupropion as an alternative. I'm assuming that's for the SSR, the serotonin transporter discussion. Maybe. Yes. Okay. Yeah. Again, maybe the evidence is, there's no evidence for or against it, so I can't even comment really. But it is something I've heard people say before. It's like, well, we'll go with bupropion, but yeah, it's hard to say. Again, I think that's why I say it's on the cusp, the serotonin transporter. I think, maybe 5 years from now, if I were to speak to you guys again, I may be saying serotonin transporter is ready to go, start using it. And here's the guidelines. But right now we haven't really sorted through all this. It's pretty messy at the moment.
Any other questions? Okay. So I think if we don't have any other questions, we will begin to wrap up. And thank you so much for this presentation. It is a very kind of conservative, less enthusiastic take on genetic testing than I think in some of the very enthusiastic clinical circles, right? Or any of us who are exposed to patients, right? Patients are very enthusiastic. They like this. They want the test results. They want to feel that their medication prescription is guided by some results, by some lab, by genetics. It's very attractive to patients. So we are working with families. Sometimes families request this and advocate for themselves. So it becomes a very interesting conversation, right? And I think especially within this group, right? This is integrative psychiatry, right? So complementary and alternative, right? So you definitely have all the early adopters are in this group, right? So, so we are definitely looking at those 12 other things on the list and are curious, could this be helpful, right? And just in clinical practice, maybe many of us are finding there's something to this. It's just hard to know. Is it because the patients are so enthusiastic, right? Or if there's really something to it. So right now, basically there's no evidence that it doesn't work. There's just no evidence, right? There's no evidence that it does work. There's no evidence that it's helpful to test. We need to wait, right? And for many of these, we may need to wait, hopefully not decades, right? To really have clarity, yes or no, it's useful or not useful, right? And I try to explain this to my patients, look, lots of gene, we can tell you what the gene result is, but the interpretation is a real art, right? And even what you said, when you compared the interpretation from 4 different tests, right? They give different guidelines, right? So it's the art. And maybe that's all of us, right? Really doing research and thinking about it and studying and accumulating clinical experience too of okay. And I know some of us in this group are definitely enthusiastic about some of these test results, and if I have a BDNF mutation on my test results and I can tell my patient, you should exercise, you have a genetic reason to exercise and they start to exercise, that will help. I don't know if it has anything to do with BDNF gene results, but if that's what it takes to get them to exercise, hallelujah, right? Everybody's happy.
So in that example, maybe I would agree with that. There's very low risk of that kind of recommendation. Again, that's not my area of expertise. But I do worry when it's that same rationale is applied to medications, because like in the case of folate, I don't have as much of an issue because of it being a relatively low risk intervention. What my worry is in that case is people would not prescribe folate based on a genetic variation, or I worry about taking efficacious medications, potential efficacious medications off the table, as much as I worry about prescribing something based on a pharmacogenetic result that's not really appropriate based on that, the evidence. So I actually am very enthusiastic about pharmacogenetics. I really am. And if anyone, you can go, if you Google me, you'll see I am very enthusiastic. It's my whole life is around pharmacogenetics, but I also want to be a realist, and I'm very afraid of hurting the reputation of pharmacogenetics by pushing it too fast, because a lot of other innovations have gone that way. And then what happens is walls go up in certain areas, and people won't bring those walls down. It's like, no, I don't trust you now. So I want to be real, and that's why I said if we follow the evidence and we be patient, we will get there. I'm totally for testing. I think, I have myself, everyone in my family is tested, but only for but I'm only allowing implementation of things that are, evidence-based. Like I don't think those other genes are ready. You can have them on standby, but I just say don't act on them right now. And I think if that is explained to patients, that's fine. But by all means, any way you can get people to exercise more, go for it. That I have no problem with. We all probably need that, a little kick to get going. And so if that does it, and there certainly is a notion that pharmacogenetics offers some type of placebo effect. That's one of the things I said. There is some emerging evidence suggests that people that are reluctant to start pharmacotherapy or have low adherence to what they were given, giving them pharmacogenetics testing, even if it doesn't provide any additional information, does make a difference. Because if it shows they're all normal metabolizers, like, oh, I feel like this drug is safer, I feel like I should try it out, right? I don't know, is that just that there is that placebo effect. And so you can use that to your advantage as well. Yeah. So yeah, I just wanted to clarify. I know I come off as very conservative, but there's a reason for that. I am actually very enthusiastic about the field. I just am afraid of pushing it too fast, too soon. And I don't want it to, get out of control. It's hard to reverse, hard to go in reverse then, so.
And I hear you, this caution that, if somebody receives this, and patients have access to their own results, right, of these large panels, right, and then there'll be 35 medications in red. And if I think that actually that medication might be good, or, but it's in red on their test results, that actually creates some difficulty, right? That's a nocebo effect, right? Now they've been planted with this idea that it's not going to work, it's not right for them, it's wrong for their genes. And maybe, then I'm actually, if I see there's a nocebo effect, likely I won't, it reduces my options. Yeah, so maybe that's.
It's a good point. And there was a paper on this, and I'm happy to send it around. It's called, I think it was an editorial, but it was well written about, it's called Beyond the Bins. It was focused on GeneSight, I believe, because they're the ones that started the traffic light thing. And a lot of the companies now have followed suit, because I'll admit, when I first seen it, I'm like, genius, traffic, that's easy. But then I thought about it more, and then the field has thought about it more, and now we're all kind of backtracking because there's a psychology to those colors. Like you said, you put something in red, you might as well just put a skull and crossbones above it. No one wants to take it. And on the flip side, the drug in the green gives a false sense of this is going to work for me. When that is not what the green bin is actually telling us. The green bin is just telling us that based on the curve of evidence, we don't have anything that would change our typical dosing and selection criteria. But patients see green as that these are the drugs that'll work, but that's not what the green means. And then yellow is, not really much been talked about, but definitely there's a psychology. So here in Calgary, when we do testing, we use a binning approach, but we do not use colors. We have like 2 shades of blue. They're just the different shades. So we've gone away from that psychology because there is that psychology to it. And we've trying to push some of these commercial tests to get away from the traffic light, but you can imagine how hard that is because it's part of their branding now.
Yes.
I think Seth was trying to say something.
Well, no, I didn't have the sense. I didn't have the sense that you were unenthusiastic at all in the beginning, and then there's this sort of letdown. There's only 2 tests, that. I mean, it's interesting that you feel that the integrative psychiatrists are ready to espouse this, even though, again, this may be my bias when I think about integrative psychiatry, but we're looking for maybe the BDNF and MHTFR piece would be, but my sort of bias is that you're looking for other options besides pharmaco stuff. So, but no, I mean, I thought it was very helpful. I think the big barriers for me and us in psychiatry is, maybe in my private practice, but in my work in a medical integrated setting, it's like, how do we fit in and all of the workflows? And, I don't have a nurse to sort of, and the nurses don't swab anyway. So it's like, and it's not being ordered, so that's really kind of like the barrier. And yes, the piece about the reporting as well. But it's interesting because I attended a talk about this 10 years, well, maybe 7 years ago. Same thing. It's like, why aren't we taking this on yet? It was the same feel like, so we're always saying like, oh, in 10 years from now, who knows? But, and like, I feel like this is something as simple as, it's not like, when patients think about like genetic testing, they're like, ooh, I'm going to find out what's wrong with me. But you explain, really what this is. And it's so kind of like, in the grand scheme of what we can do in medicine, it's sort of minor. And yet it's taking so long for us to espouse it because of these barriers. But I also wonder sort of about psychiatry. Like, I hear what you're saying about the red, yellow, and green and how it's sort of a branding thing, but we always have labs that are red. That when I review labs, I see whether there's a flag on it. I mean, that's just normal. It's not. It's how and so we can say that the practice of medicine in general, not just psychiatry, but has that element in it, because we're just looking for flags in our quick work. We're not thinking about, oh, what's the what is this particular lab and what's their cutoff. I mean, we should be maybe, but we're really just quickly looking for the cutoffs and what's red. But when it's about this, I don't know, is it because it's a psychiatric test that we're more conservative and quizzical about it?
Yeah, I think the red for this one is more because it's actually, the red is the interventions are in that box. In your lab report, it's saying, oh, this is over the threshold level. Like a TDM, it's saying, oh, they're over it. The patient's not looking at that and saying anything, right? That's more from your from the physician's perspective. But if you were to put, like CBT and DBT and other things in red, yellow, green boxes, that wouldn't happen. Nobody's doing that. Although actually, I shouldn't say that. There are people doing that. It is coming, but not maybe yellow, red, green, but they're trying to use genetics and other things to personalize that. But that's kind of what I'm getting at. Is like the interventions are going into the box. So it's hard to get people to get excited about something that's in that red box, even if, like Peter was saying, like it could be the best drug option given their current circumstance and their symptom profile. Like, I really like to trial this for you, but they see it in the red. They're like, no way. And sometimes I'll say drugs get in the red that aren't necessarily dangerous for them. It just made the dosing adjustment. It just needs to be pretty drastic. It's not like it's going to cause them a severe drug reaction. So yeah, I mean, a lot of it has to do with that education. It's that shared decision-making piece. But there's the psychology there for sure. And it's, you know, you probably can reason with some, but others are like, no way, it's in the red. I'm out.
Yeah.
So
yeah, I definitely think the biggest barrier for me, and I assume a lot of people in sort of a clinic setting or in a medical integrated care setting, you know, is just those practical workflow things, unfortunately. You know, it's really unfortunate.
In a private practice setting, it's actually extremely easy.
Yeah.
Especially now, you like, you know, go to the website, click a few things, and the kick is sent to the patient. The patient deals with everything, collecting, mailing, paying. Like, it's very easy for me.
Yeah. Not so easy for the patient, but yeah, you know, I mean, you know, it's not as easy as getting a lab collected. Yeah. And they have to, you know, and now maybe insurance is covering it more, but before there was a whole process with, because you know, there's a whole process with how can I get this covered, or how can I get a reduction in cost for it. But
and Chad, do you see in the future that like different therapies or TMS or biofeedback or you know, like what else will get added to this line of research to guide treatment in psychiatry?
It's really exciting, actually. There's a group in Stanford that are doing biotyping, they're calling. I think that's what they're calling it, biotyping. Lena Williams group at Stanford. And basically what they're doing, they're using brain imaging and they basically saying there's biotypes, there's certain connectivity. I think they're using fMRI, and the connectivity will, and they've shown in not trials, but studies that certain biotypes people are more likely to respond to, let's say, CBT versus medication. And others it's better to start with medication rather than CBT. So it's really exciting stuff. And you can imagine, and I've talked to her about this, like connecting that with pharmacogenetics, and then you're bringing in some of the other new stuff that's coming on, which is like the metabolomics and microbiomics and all this stuff, right? You know, that we're definitely a ways away from using in clinically, but you can imagine how you can kind of bring all these omics under one roof and bring it together. I think we'll get there at some point. Cost is a big prohibitive factor at the moment, but just like genetics used to be extremely expensive, and now it's not, all those other things will come down as well. But I do think this is going to go beyond medication for sure. I hope so. I definitely want to see it go that way. And I've definitely seen the inkling of it already, particularly with Lena's group there at Stanford. I think they're doing some cool stuff. And they're getting ready to probably try to, I guess, market it, I'm guessing at some point. But it's imaging, so it's a difficult thing to do. That's not something you can just click a couple buttons and do, and that's going to have a different cost. So that's going to be a bit more challenging to implement. You can't implement that by the mail.
But that's very exciting, right? So maybe in the future, these like swab panels will include, I don't know, like do a little thing over your head and a stool sample for microbiome and who knows what else. Yeah. And then you'll be telling us, wait, the evidence is not there. Well, 50 more years.
Well, I do believe that it's important to follow the evidence, if nothing else for just liability purposes. I mean, it hasn't come yet, but I do feel like there is going to be a litigation wave. It hasn't really happened, but I think it is going to happen. It happens with every new innovation. It hasn't happened with pharmacogenetics yet, but I do think it's going to happen. And so I would just be weary about that a little bit. You know, it only takes one case to be successful, and then the lawyers it'll be all done.
It sounds like you have this fear, like, you know, it's like psychedelics, like people got too excited with psychedelics and the whole thing got like shut down for 5 decades.
There is
So
a little bit of that. Yeah, there's I like managing the hype a little bit, because too much, I like a little bit of hype is good, but too much, and then people start raising eyebrows, and then a lot of people are like, yep, shut it down. This is getting out of hand. And the FDA has already shown signs early before the pandemic that they were going to clamp down on pharmacogenetics. So, but then the pandemic kind of saved the laboratories because they start focusing on the vaccine. So they were issuing letters to companies saying cease testing, and a couple laboratories went under because FDA was saying that they were providing pharmacogenetic testing that wasn't evidence-based. So, and marketing it inappropriately as well, saying that they can predict like the exact drug you need and all that stuff. So, you know, there's a lot of the marketing bit as well. So, yeah, at the FDA this is on their radar. And so I don't know what they're going to do. I have no idea. I don't have any inside scoops, but the feeling was pre-pandemic is that they were going to do a clamp down on a lot of these commercial labs. I have no idea what's going to happen. And a lot of them got scared and started kind of only following like CPIC guidelines. Others like, well, they haven't slapped anyone in the hand yet, so we're going to keep going and hope that they don't get slapped first. So anyway, just to keep in mind, it is on the radar, and it's a very moving target. There is no regulation at the moment, so it's bound to happen at some point.
So we're at time, so we'll have to pause. Thank you so much. You're a wonderful presenter. And thank you so much to everyone who attended. And this talk was recorded, so will be available for other people to view later. And thank you for answering so many questions beyond your presentation. And it's such such an interesting area of research.
Yeah, I enjoyed it. Thank you for everyone for